various approaches. Let's start with what may be the best known of policy proposals, Bernie Sanders' Medicare for All. This is possibly the most talked about healthcare proposal plan. I'm not sure it is the farthest along in terms of political progress, but since the campaign when Senator Sanders first introduced this idea, he has converted it into legislative language that you can follow online, and some of the questions that were open about it during the campaign have been answered. This is in some ways, might be considered the ideal type of program because it provides, it attempts to provide everything for everyone, true universal health care. Covers everybody in the United States, guarantees everyone the right to choose their health care providers, has comprehensive coverage of all medically necessary services, hospital emergency outcare, preventive drugs, which are covered in all programs, and more generous than some proposals in terms of mental health, dental, and vision coverage. It does envisage that there will be some administrative agency which will make the crucial determination of what procedures are medically necessary, so it doesn't open the door to anyone that says, I'm a healthcare provider, I can lay on hands or whatever and cure you, but it's pretty broad. Would be administered directly by the federal government, and people who participated in it would get their services from Health and Human Services directly. It's not quite a universal program in the sense that it does allow both providers and patients to opt out of the program if they don't like it. The opt-out provision, it looks to me when you read the legislative language, is quite similar to what they have in England, where the National Health Service also provides universal care at no cost at the point of provider. But in practice, in England, about 18% of total healthcare spending is outside the national healthcare system, which includes for some services that the national health does not include medically necessary, and also includes sort of Cadillac services or Rolls-Royce services, we might say, for people who want to skip the lines in the National Health Service, somewhat like concierge medical care in the United States. And I imagine that if Sanders' plan were implemented as it's written up now, that there would probably be maybe 10%, 20% of the healthcare system would remain in that category in the United States. So this is a sort of a benchmark. It's the maximum that anybody's proposed, but it would be expensive and it would be difficult to get there in one jump. So a number of people across the political spectrum have looked for ways to accomplish the main goals, the type of goals that are laid out by the League of Women Voters position, in a way that would be have less of a burden on the federal budget. I'll look at a couple of these in particular, although there's others out. One of them, which comes from the Center for American Progress, one of the leading liberal healthcare think tanks or general policy think tanks in the United States, is basically takes the Sanders plan and adds a good deal of cost sharing. Under the Medicare Extra plan, as this is called, it would make full coverage available under the framework of Medicare system for everyone at a level scaled to income. For people below 150% of the poverty level, which is about $37,000 for a family of four, there would be no cost sharing, no premiums, no deductibles, and no co-pays. For middle class, range 150 to 500%. There would be a sliding scale of deductibles and copays, and above 500% of the poverty level, there would be a maximum amount that people are expected to contribute. The Medicare Extra plan comes with a full range of cost savings, proposed cost saving measures, including, as in the Sanders plan, some type of agency which would determine, as is now done under Medicare, which services are medically necessary and which are not. It would extend, as all of these programs I'm going to discuss do, extend the right of the government to bargain over prices of services and drugs, which is believed to be significant cost-saving measures, and also use, by consolidating more of the program in the hands of Medicare, would presumably save administrative costs, since administrative costs per participant are quite a bit lower for Medicare than they are for the private sector. So it has a strong range of cost controls, and Medicare Extra plan, if you look it up online and read about it, you'll find spends a lot of time talking about the complex issue of transition from the service, from the situation that we have now to something else in the future. Transition process is actually very complicated, because public opinion indicates that substantial majority of Americans, despite all the complaints we hear about the medical system, a substantial majority of Americans are satisfied with the care and the provision that they themselves get now. Often that means care through their employers, and so they have an elaborate plan for not immediately eliminating employer-provided insurance, but rather providing incentives that would move both individual workers and their employers gradually away from this. However, despite the gradual nature of the transition for people who now have employer-provided insurance, which is about half of the population, the Medicaid Extra program would become available immediately for everyone who is currently uninsured. Another program, a variant on this program, another way of extending services that would also fit within the guideline of the League of Women Voters national policy position, is an approach called universal catastrophic care, or universal catastrophic coverage, which I myself have written quite a bit about for the Niskanen Center that I work for in Washington. Niskanen Center is a nonpartisan think tank that particularly focuses on problems of social policy, health care, environmental issues, and related issues. The idea of universal catastrophic care, is an old idea, has been floating around for a long time, is that if we can't do everything at once as it approaches, as the approach taken by the Sanders plan, trying to do everything at once, we don't want to do everything at once. The most important thing to do is to provide a type of national insurance that would protect people against the threat of financial ruin as a result of healthcare problems. So the idea is that everybody has a cap, not on what total that can be spent on their care, as in the example Barbara gave, but rather a cap on what they have to contribute, with the government taking over in case of catastrophic events such as cancer or chronic diseases like diabetes that have ongoing expenses. Again, the idea here is to make the program affordable through cost sharing, and the cost sharing could be any mix of premiums, deductibles, or co-pays, provided that it was affordable. In the version of the plan I've most written about, the idea would be that people who are below what is now the Medicaid threshold, which is about $35,000 for a family of four, $16,000 for an individual, as Barbara said. Below that threshold, the cost sharing would be zero. There would be, for those people, there would be no co-pays, no deductibles, and no premiums. And above that, people would pay a maximum, have a maximum out-of-pocket expense, maximum cost sharing that would be some set percentage of the amount by which their income exceeds that low-income threshold. For example, if the low-income threshold is $35,000 and your family income is $75,000, and the maximum is 10%, then you have $40,000 of eligible income. Your maximum out-of-pocket expenses would be about $4,000. That includes premiums, co-pays, and deductibles. So this plan would be quite a bit more generous than policies for middle-income people under the Affordable Care Act. There would, as incomes went up, your cost sharing would go up. Hypothetically, if you had $1 million income, you might be required to contribute $90,000, $100,000 a year to your care if you became ill. So if you needed Gleevec at $140,000 a year, you might be on the hook for $40,000 or $45,000 of that, plus ancillary care. Question often arises, what do we do if we cover only catastrophic care? What do we do about preventive services? The answer to that is that all of these plans I've discussed, including catastrophic care, waive co-pays for preventive care that's cost effective. If you have screenings, vaccinations, whatever, that save money, you take care of things early, those are covered without cost sharing. It's an open issue for political consideration whether or not these catastrophic coverage would be provided directly through the government as our Medicaid or through some private-public partnership as our Medicare Advantage plans. That is, would it be more like the British system, which is national health care with the government as a single payer, or would it be more like healthcare systems that we have in countries like Germany and Switzerland, where we have private insurance companies that act as government contractors under strict regulation and price control to provide the services. So those are three different approaches. There are some other plans floating out there too. A couple of weeks ago, there was a group of senators advanced a plan called Medicare Part E. The E stands for everyone, and Medicare Part E, somewhat like the Medicare Extra plan, would simply mean that anybody who wanted to could buy into Medicare Extra. A somewhat still more restrictive version of that is the idea that's been advanced by Senator Stabenow, who has proposed that we gradually lower the age for which people can qualify for Medicare. For example, I think your immediate proposal would be that people 55 and older could buy into it at an appropriate premium. So the question everybody asks is this affordable? Well, yes and no. It's affordable in the sense that we now spend 16, perhaps more than that, 16% or more. This was as of 2013. It's more like 18% now of GDP on Medicare. None of these plans propose necessarily spending more, although some of them do change the mix between what's public and private. You can see that in the United States, about half of all medical spending is now private and about half public. The public share is smaller than in most countries, although there are a few countries out there, including Israel and Chile and Mexico, that also have high shares of private, but those are lower income countries that have lower total expenditures. So we can play around with so the big issue is not whether we spend more or less total on health care. Almost everybody believes that it's possible to spend somewhat less, but how we divide that up. How do we pay for it? We can pay for it in part. One way to pay for it, as under the Sanders proposal, would be simply to shift most of this spending to the public sector. Most of what is now spent privately shifted to the public sector through the tax system. If we do that, we have to either raise taxes, cut back on other programs, or run bigger deficits. Those are considered major political barriers to the major political barriers to the Sanders program. The alternative of facing these difficulties for the federal budget is to offset broader coverage with more effective cost control and with effective cost sharing, but allocate the cost sharing so that people who can afford it pay their share, people who can't afford it get the care they need. Where would that put us realistically in terms of the position in the world? When we look at this chart of how the United States does relative to countries like Australia, UK, New Zealand, the Netherlands, and so forth, it looks like we're a long part away. These countries are doing much better than we are for much less. Why can't we just do what they do? Why can't we just copy their systems? Few people think that it is realistic simply to choose one of these international systems, drop it into the United States, and expect it to function as it does there. Unfortunately, the United States is coming late to this game of universal health care. At the time that Britain introduced its healthcare system, right after World War II, total healthcare spending was a couple of percent of GDP. So they've grown up with it. They've managed to control costs over a period of decades. They haven't had to turn around and tell some provider that they're going to have to start accepting a third of the reimbursement after they already have invested in all of their education, all of their equipment, and so forth. What we can reasonably expect to do, the reasonable paths for reform, and this includes Sanders, it includes Medicare Extra, it includes Medicare Part E, it includes universal catastrophic coverage. What we hope these can do is to greatly improve the performance of the system without greatly improving cost. Move up somewhere in this direction. Not quite joining the center of the pack, but at least getting a lot more in terms of coverage from the money we're spending now, or in the case of the Sanders plan, which is the most generous, perhaps getting universal care for everybody without cost sharing, with only a slight increase in spending. Unfortunately, much of the healthcare policy change that's going on at present is going in another direction. There are many people in government who are, instead of prioritizing expanding coverage, are prioritizing reduced costs. And as a result, at the moment, we're moving in this direction, down and to the left, hoping to achieve some cost saving, but doing so at the extent of having fewer people covered than before. So those are more or less the options. Those are some practical solutions that people have proposed. There's a lot of people out there thinking about these programs, and I'll leave it there and have questions for Barbara or myself, please.
Is this on?
It's not.
Okay, I think it's on. How about if I just talk without that? Right now, the Medicare system makes an attempt to subrogate in situations where they think somebody else is responsible for a Medicare eligible person having Medicare expenses. Do you have any idea if that program, if that whole thing is cost effective, and if it would continue to exist if we had Medicare for all?
I'm not quite sure I understand you, but
Could you repeat the question?
I'll rephrase it. So, Ford Motor Company makes a car that they know has got a defect. And you're driving down the road, and lo and behold, the defect makes itself manifest, and you're hurt through no fault of your own because Ford Motor Company manufactured a defective car. So let's say you're on Medicare, and Medicare would then subrogate the cost that Ford Motor Company caused you in medical expenses so that they could recover it, right?
If there's a personal injury settlement and the claimant is on Medicare, or likely to be on Medicare in the near future, Medicare wants a piece of the settlement to make up for the money they're going to spend. It's a very complex system. I question whether it's really cost effective, and I wonder what the future of that would be if we have Medicare for all. In other words, if Medicare is paying everybody's medical expenses for everything, would Medicare then try to recoup some of that from other parties who they think are responsible for the Medicare costs?
Yeah.
I'm
So,
thinking it could get
yeah, I would assume that they would. I haven't seen any specific proposals for that. I think that sounds like, in principle, it sounds like similar to environmental disasters. When the Gulf oil spill came up, the government provided a range of emergency services and housing services and reimbursements for that, and then they tried to get what they could out of the company that caused the damage. So I would assume that. I agree with you, these things, these procedures are expensive and they don't always work well, but I don't think there's any reason that they would disappear.
Just one note on the microphones, these two are on the same system, that's why they're screeching. Can we just go to the handheld on the microphones? Because this one seems to be screeching now. Our second handheld is not.
Is that working?
Okay. Would you speak louder?
Is that working?
Yes.
I'll speak loud. Is Plan 3 on your last graph here?
Plan 3?
Yeah, your third plan, is that on this graph?
Universal catastrophic coverage, yeah, right here, universal
That's,
catastrophic
that's,
coverage.
where's 2 then?
They're both on the same arrow.
Oh,
I
I
think both
see.
of them are designed,
Okay.
they have in common.
Oh, I
As a matter of
see it,
fact,
yeah.
they're not too much,
I got it.
they're not greatly different if you actually look at the numbers for them. They have a slightly different political history. The ideas for the universal catastrophic coverage is a plan that has origins on some I would say, center-right origins. There was Elliot Richardson had a very similar proposal back in the Nixon administration, came surprisingly close to being adopted before Nixon unfortunately fell by the wayside. The CAP side plan comes more from the progressive side of the spectrum. But if you look at the actual numbers, the way they allocate cost sharing, no cost sharing for people below the poverty line, moderate cost sharing for middle class, and aggressive cost sharing for high-income households, they don't differ that too much. I should say that in general, I haven't identified these programs particularly as being left-wing, right-wing, center. If you look at proposals and discussions across, not across politicians in Congress, but across policy experts, from the American Enterprise Institute to the Center for American Progress, you tend to get pretty much the same answers to these issues. Everybody's agreed on the concept of what needs to be done. Packaging it up to get it through Congress is another problem. But since I'm only a policy analyst, I'm sort of like Werner von Braun, you know, the old line, the rocket goes up, who cares where it comes down? Yes.
Yeah. I just wondered if any of these plans or anything in consulting have discussed the issue of student loans for medical students and the fact that they end up with this enormous debt that they have to pay off. And it seems like if we did a better job of subsidizing their education, that maybe we could save some money that way. I mean, if they were given the kind of plan where, you know, for every year of practice you get so much of your loans paid off. So is anyone talking about that?
Yes, people are talking about that. And if you had a healthcare system where all of the costs ultimately fall on the government, those are going to directly or indirectly include the cost of medical education. Countries like the United States and some other countries where people pay for their own medical education, that shows up as higher physician salaries. And countries where medical education is more subsidized, physician salaries are lower. So U.S. Physician salaries are quite high, and that has an impact on how much we spend. In fact, if you correct these numbers on national health care expenditure in a way that accurately captures the cost of medical education, some of those other countries are spending more than we see now. But there are many reasons to think why it would be more efficient, as long as the government is covering the cost of health care in general, to put at least some of that money into subsidizing medical education rather than the system we have here in the U.S. Yes?
So let's be optimistic that 1, 2, or 3 is moving forward and would be adopted. But could you, either of you, address how or why we could be able to expect that we would have more medical practitioners in rural areas such as in Leelanau County? I mean, is there a connection if we have better health care, that there may be more doctors willing to reside here and to have an office here?
So I think there is a connection in that one of the issues that prevents people from coming here is there's not enough people in the practice. And there are not enough people, for example, in Northport in the practice to have that practice thrive. But there have been notable increases in people coming in since the ACA came in and Medicaid expansion. So I think that I think there are potentially ways to incorporate high quality medical care in rural areas, not just here. But we have to use the technology that we have. I think people don't want to move. They live here for a reason. They don't want to move to high population areas. but they still have the same needs. So I think we can get creative. I think that one of the things that physicians don't particularly like in general is having to spend Monday in Charlevoix, Tuesday in Alpena, Wednesday in somewhere else. And, you know, it's sort of hard on your family life, and it's hard on your continuity for your patient care to do that. So how do we actually build this out? You may have noticed there's a blossoming of nurse practitioners and PAs, and many people are getting